For our final episode, we are talking about the use of Narcan and the care of our overdosed patients. So as I was putting this presentation together, when I picked these topics back in, I think it was July of last year, I was going through topics, and obviously this is the last one, mostly because I kind of struggled with this one just a little bit. My personal thoughts on Narcan, I initially wasn't going to put into this presentation, but as things kind of started progressing and I started doing a little more research and taking a look at Narcan protocols and EMS's use of Narcan and so on, I found that my opinion of Narcan and the use of Narcan is not uncommon in EMS. So this presentation might go in a different direction than you think, and I hope it lives up to what you guys are expecting out of these presentations. But let's dive into this and let's talk about Narcan and the care of the overdosed patients. Not really sure how long this one's going to go. We might be done a little bit early. As you've probably known, after spending a couple months with me, I can get a little long-winded. So I guess we'll just we'll wing it here, and we'll see how long this presentation is going to take. I got a lot of great information I want to get to, so let's get started. If my clicker would work, that would greatly appreciate it. So here we go. The overview of what we're going to cover is I want to talk about the drug itself. I want to talk about when we should be using it. I want to talk about when we shouldn't be using it. I want to talk about the dosing, whether that's the intranasal dose, the IV dose, the IM dose. I want to talk about what our care for these patients are when they are when they are resuscitated from that overdose. I want to talk about some of those priorities, and of course, safety is a big priority of mine, as you probably already know. Also, what I want to talk about is this idea of, are we abusing the drug Narcan itself? And I'll kind of talk about that. I kind of just want to plant that seed a little bit. And then I want to talk about, it was in an article that was published through GEMS just about a week and a half ago. I want to talk about this alternative method for giving Narcan, to just plant a seed to maybe make you engage your medical program director within your agency and bring this idea to the table, and maybe see if you can get the wheels turning in the right direction to maybe change the way we give Narcan and so on. So that's kind of the overview. Again, it says 1.5 hours. I guess we'll just see how long we go with this one. So first off, I wanted to kind of look at the overview of why, it seems like a really specific topic. It also seems like a really straightforward topic if you think about it. It's not something like OBGYN that's got some complications, or we've talked about penetrating trauma, we've talked about shock in general, and so on and so forth. But I really wanted to just take a look at this one for a couple of reasons. Number one is the recent statistic is every day more than 130 people in the United States die after overdosing, on opioids. So we know this problem is becoming a bigger issue in EMS. We know that we're starting to see more patients that are overdosed on our streets, in the houses we're responding to. I don't know about every one of the agencies that's tuning in, but I'm sure that we've seen an increase in our opioid overdose call volumes. So I wanted to take a look at that for that reason specifically. One of the things I wanted to chat about real quick was this interesting statistic of about 80% of people who use heroin first misused prescription opioids. And what was an interesting factor of this is taking a look at that, a lot of the heroin users that these agencies are encountering actually started as work-related injuries that were prescribed oxycodone, hydrocodone, or some sort of opioid-based painkiller. And when that prescription runs out, their addiction has become so dependent on that drug that they then seek out alternative methods of getting that high feeling that those drugs gave them. And of course, heroin is easily obtainable on the streets. And so we are seeing a fairly big increase in these call volumes. The other one, obviously, is if you've been reading in the news or been doing any research, you know that there are other synthetic opioid-based drugs, for example, carfentanil, that hit the streets in the United States not that long ago and was causing some pretty substantial problems because of its potency. It was actually originally designed at that potent level to tranquilize elephants. And so that potency of that drug, carfentanil, is much, much more than those patients are used to. And it's causing some pretty substantial damage and problems within our EMS communities when it comes to overdoses. So those two factors. And then this one is the opioid overdoses increased 30% from July 2016 through September 2017 in 52 areas and 45 states. I didn't look specifically at what states those were, but I got to assume that we probably have people from those states or, or at least close to those states are logged on tonight. So I knew this was probably a topic that is growing in our area. So I just wanted to kind of take a look at this and just remind ourselves how to care for that overdose patient. And of course, talking about this drug of Narcan. If you want to throw in the chat box as I move on to the next slide, let me know. And those of you within Washington State, you don't have to tune in on, or you don't have to chime in on the chat box, because I know you guys have Narcan at the EMT level within the state. Whether or not your agency or county allows that obviously is up to that agency or county. But the other states that are logged on, if you want to message me on the chat window and let me know whether or not your state is allowing EMTs to give a Narcan. And if not, I want to maybe try to give you an email so you guys can get some resources if that drug isn't currently within your scope of practice. I do know that in 2020, the guideline change for NREMT is going to officially add Naloxone, which is a opioid antagonist. It's going to add that into the national EMT scope of practice. So it's going to become definitely a much more common drug that's going to be given by EMTs. So you want to just throw in the chat box though, if you don't give it, or if you do give it outside of Washington State, that'd be good just for my own personal knowledge. So locally, what's interesting is I was building this presentation, I don't know how long ago, to be honest with you. I've been kind of working on it over the last couple of weeks, but there is a couple of options. Let's see here. I'll look at the chat window here real quick. Both pieces, people mentioned in and said Montana with an endorsement allows the individuals to, EMTs to give Narcan. So that's good. But what I wanted to look at is locally here in Spokane, what we're dealing with when it comes to this quote unquote increase in opioid related calls. And as I was building this presentation, if you're a social media person like myself, here in the Spokane and surrounding area, there's a page called Spokane News, and Spokane News is kind of monitor scanner traffic and post updates and post calls and dispatch information related to medical calls and fire calls and law enforcement calls and so on. So as I was building this, building this presentation in just one day, this all occurred on the same day. There were 3 separate calls. And if you look at these upper left-hand corner, Hamilton and Sharp, Spokane Police Department reporting they have just used Narcan on the subject, and medics are responding as well. The bottom left-hand corner, 400 South Thor, officers on scene reporting a heroin overdose, and they have given 2 doses of Narcan. Also, a passenger fled from the incident on foot. So a couple different unrelated incidences there. And then this one on the far right-hand side, I feel like is a little bit more concerning, which is 200 East Indiana reported 2 juveniles have overdosed. This literally all occurred within the same day when I was building this presentation initially. And so I just taken some screenshots of that to show you that it's definitely not isolated areas, Midwest, back east, or, whatever side of the state. This is occurring just about everywhere that we are aware of. And so I just think we need to kind of remind ourselves what this drug is for, and just the generalized care of overdoses, because I think we're putting the wrong attention towards the wrong priorities. So that was my goal with this presentation. Someone's trying to chat. Looks like one of the mics is unmuted. Got that taken care of. Okay, good. So here's what we know about Naloxone itself. First off, it's also known as Narcan, right? That's the registered trademark of that drug. That's that brand name or trade name. By definition, the way it works is it's an opioid antagonist, and we're going to talk about that here in just a second. Naloxone is used in opioid overdoses to counteract life-threatening depression of the central nervous system and respiratory system, allowing an overdose victim to breathe normally. Now, don't read any farther than that slide. I want to point something out, because I feel like this is where the main problem with this drug lies. If you look at this, it specifically says, and this was taken from the naloxone pharmaceutical pamphlet or insert, whatever you want to call. I want you to look at this. It specifically says the whole purpose of this drug is to improve the respiratory depression that's life-threatening of that central nervous system, and it's allowing the overdose victim to breathe normally. Now, here's the problem. A lot of us believe that Narcan is designed to make our patients conscious. And I'm going to tell you, by the end of this, you probably don't want these overdose patients conscious. You just want them to breathe better. You want to make their lives just a little bit better. You want to get them oxygen in and out. You want to manage that airway and breathing. But you really, truly don't want these patients awake and interacting with you, because I don't know about you guys. I see some people laughing in Colfax. Maybe you guys know what kind of interactions I'm speaking about. So I don't think these patients you want to be interacting with. So my recommendation is make them breathe better, but just leave them on the unconscious side. I feel like it's a lot safer if they're just asleep and breathing better. But we're going to talk about that a little bit more. You're going to find out that I have an interesting opinion of Narcan. So we'll get there here in a second. But the injected form of Narcan that's being injected into the IVs or something along those lines comes in a much, much lower concentration. I got to laugh. Stacy from Montana just messaged and said, titrate until nice. I have never heard that. Stacy, I am taking that from you, and I am coining that as my phrase. You can't have it anymore. It's now trademarked as the Sean Pitts version of that. She said, please do. Awesome. Now I have her permission. So titrate until nice. I love that. We're going to come back to that. I love that idea. So sorry, I got derailed there for a second, but of something that funny and something that worthwhile, please derail me anytime you'd like. But the injected version is going to be 0.4 milligrams is equal to 1 milliliter. The version that most EMTs are giving is going to be the sprayed version, which is the 2 milligrams equals 2 milliliters. And here's the other big thing, and I feel like this is a pretty broad window if you ask me, but it's a temporary drug that wears off in 20 to 90 minutes. Now, here's the good news. Those individuals have taken some sort of opioid-based drugs, and we give them Narcan, and you made the mistake that they woke them up, and you didn't follow Stacy's very, very good medical advice of the titrate until nice, and you titrated until they were a jerk, and now the patient's being a jerk. Good news is, hopefully you're closer to the 20-minute range and not so close to the 90-minute range, and that Narcan wears off, and of course that patient goes back to being sedated and not nearly as agitated, and you can try this again. And we're going to talk about this whole dosing thing, because I think that's some of where our problem lies. So we'll come back to that, I promise. So I found this little diagram, and I don't know if most of you have seen this or not, and it's kind of dark, and you really don't need to read most of the presentation or the slide, except for you got the opioid receptors on the brain. I'm going to pull my little annotation out here. Wow, it looks a little bit different than last time. You got your little opioid receptors here on the brain, and what happens is the individual takes the opioid, right? And that opioid locks into that, and it fits exactly onto the receptor just the way it's supposed to. Now what happens is, as our body starts to use that drug, it causes respiratory depression. Now, when you give Narcan, all Narcan is designed to do, it doesn't do anything to the heroin floating around in their body. All Narcan is designed to do is to lock onto those receptors in the exact same way that the heroin or the opioid or whatever type of drug on the opioid side, it locks onto it just like that. So it bumps the opioid off, and that opioid is now just floating around in the bloodstream. Now, again, the little green Narcan pieces here that are locked on only last about that 20 to 90 minute range. I don't know about you. I don't know if anybody's had it last up to 90 minutes, but I feel like 30, 40 minutes about the max time I've ever seen Narcan last. But it sits there and just kind of prevents the opioid from locking onto the receptor. Anywhere between 20 and 90 minutes, that Narcan is going to get metabolized and it's going to pop off that receptor, and then that opioid is going to click right back onto there, and we're going to have our overdose patient again. That's not necessarily a bad thing, because we're not trying to keep them awake long enough for their body to metabolize and filter out that drug. We just want them to breathe better, okay? That's the whole idea of what this drug was designed for, okay? And we're going to come back to that multiple times. By the end of this presentation, you're going to be like, dude, I get it. Good. I really think that we should pay attention a little more when we're giving this drug and why we're giving this drug. So here are the official indications of the drug. And I'm going to give you the official indications, and I'm going to give you what what Spokane County says. But this came right from the pharmaceutical company as well. Narcan or naloxone is indicated for the complete or partial reversal of an opioid depression, including respiratory depression induced by natural or synthetic opioids, including those medications. I'm not going to attempt to read some of those, but methadone, morphines, those kinds of things. Narcan is also indicated for diagnoses of suspected or known acute opioid overdose. So really, the key words here I want to draw your attention to is this idea that it is for complete or partial reversal of a respiratory depression, okay? Respiratory depression is going to be the key word there. And then, of course, the list of drugs that goes beyond that. Now, what's interesting is in Spokane County, and again, I'm just basing off of what I know and what I operate under here in Spokane. Spokane County has 3 possible reasons why you could be giving Narcan. Let's take a look at those. So, let me throw my eraser on here real quick. Whoops, that's not the eraser, dummy. There we go. So let's take a look at this. So here are the 3 reasons. Number 1, you have a suspected opioid narcotic and or synthetic narcotic overdose, including the following agents. And it lists, there's your morphines, there's your heroin, there's your codeines, there's your Nubain, there's your Suboxone, there's your Tramadol, there's your Fentanyl, there's your methadone, and so on and so on and so on. So you have a known overdose of one of those medications, and we can go ahead and give Narcan, okay? Now, also, you got a known narcotic overdose with a respiratory depression. Now, let me ask you, how would you know that this is a narcotic overdose? Either unmute your mic or throw it in the chat window. How would you know if this was a narcotic overdose? I hope we pronounce your name right. Is it Noni? Pinpoint Pupils, Spokane County Fire District 5. You said it as well. Stacy, you guys got it. So Pinpoint Pupils, we know that your pupils will be indicative of those narcotic overdoses. Lincoln County Fire District 6, you guys have a really good point. The scene around them, right? Obviously, if you have those individuals that are using heroin, needles, burned spoons, pour needle practices, things along those lines, absolutely. I don't know what SMH stands for, but SMH ambulance in Plentywood, it says occurs in the hospital setting. Absolutely, this can also occur in the hospital setting as well. So we got the suspected opioid narcotic, and then we got the known narcotic overdose. And then what I feel like is, I'm not like talking smack about Spokane County's protocols. Please don't call anybody that actually controls these protocols. But I'm not a big fan of this coma of unknown origin part of this. I think this is where we kind of got off track with Narcan. If the patient is unconscious and we don't know why, I feel like there's a couple other things that should be high on our priority list, not giving our patient Narcan. And we're going to come back to that. I just am not a big fan of number 3. I like number 1. I like number 2. I'm just not necessarily a big fan of number 3 in this circumstance. So, Dr. Jim, if you are listening, I'm really sorry. I'm not talking smack. I'm just saying that it seems kind of broad there. But we'll come back to that. So let's look at like those key points here. I want you to look at something. Notice in this, both of those indications, we talked about the word overdose and the word respiratory depression. Now, I think we all know what respiratory depression means, but maybe we didn't realize what the word overdose means. And the word overdose, by definition, is an excessive and dangerous dose of a drug. Now, you probably can agree that if they just took a daily dose of, let's say, a Hydro 5, right? I don't even know for sure the milligrams, what they come in, but a Hydro 5. And they're supposed to take that 2 or 3 times a day for their chronic back pain. We probably can agree that if that person is on the floor and they're slightly altered and they're really not making sense, there's no reason to give them Narcan, right? Narcan is designed for our patients that are A, overdosed, or B, are respiratory depression. An overdose is an excessive or dangerous dose of the drug. If they're supposed to take it or they've taken the prescribed dose, why are we giving Narcan to those individuals? Now, if they have respiratory depression, absolutely. Let's give them that dose of Narcan and let's make them breathe better and let's titrate to nice and let's see what occurs. Okay, and we're going to talk about the whole idea of giving this drug just to rule out the possibility of overdose here in just a few minutes. So here's what I will tell you. Your number one priority in these overdose victims should not be going for the Narcan, right? Your number one, if you look at Narcan, Narcan is a drug, which means it's an intervention. And if you remind yourself of those skill sheets and the NREMT side of things that we all learned at some point, I'm sure we've forgotten them by now, but that intervention piece to this order is way down towards the bottom. There are a couple things that should be occurring before we're giving these interventions. And I've made the argument before because I've been there where I'm like, well, wait a second, if I give the Narcan, it will fix the problem. Yeah, but your priority is airway, breathing, circulation. Giving this drug is about breathing, not level of consciousness, okay? Our biggest priority should be making these patients breathe at the adequate volumes. Again, it's more about volume than it is about rate, but adequate volumes. Most of these patients' tidal volume is extremely low, okay? Tidal volume is a really important factor of your respiratory rate that we need to be paying attention to. And if the volume is low, we got this cool thing called the BBM. If their rate is slow, we got this cool thing called the BBM, right? We don't have to reach for the Narcan right out of the gate and just start slamming Narcan into our patients, unless, of course, you don't like the people around you. If you don't like the people around you, Colfax, I'm talking to you guys, then slam the Narcan and just surprise and take a couple steps back and let those people have a good time. And I'm going to talk about that here in 1 second. But if that is the case, when it comes to ABCs, we should be doing ABC things first, not Narcan. Narcan is down low on that priority list. We should be doing things like airway control. Is our airway open? Is our airway clear? Is our airway maintained, right? I think it's kind of silly that a lot of these overdose patients, we never even use a BBM. We never even use an NPA. I'm a big fan of not using the OPA in a lot of those overdose patients because most of them have a gag reflex. But why are we not dropping NPAs? I feel like NPAs are a pretty good, underutilized airway device that's fairly non-invasive. And especially if you got someone who's just barely unresponsive, I feel like dropping that noodle inside their nose is a pretty darn good way to initiate a response, if you ask me. So why don't you drop one of them little plastic noodles inside their nose, and let's see if that gains some sort of appropriate response out of your patient, okay? I feel like that should be on the GCS scale. Did they wake up with noodle insertion in nose, okay? But open it, clear it, and maintain it. The other big one is if your patient is overdosed and they're not breathing very good, they're likely to vomit. And it always happens that we attempt to lay these patients flat on their back and allow them to lay in that supine position where airway control is at our benefit. If they're breathing just fine and they're overdosed, those patients belong on their side, because when they do start to vomit, we want that vomit to fall out. I've been using this example in a class I teach on a pretty regular basis, and I've been using this example of, if you want to know what it's like to have vomit in your airway and you can't control it, why don't you take a big, nice drink of coffee, lay flat on your back, have someone plug your nose, and when it comes time for you to take a big, deep breath, I want you to open your mouth, spit out all that water, and then or all that coffee, and attempt to take a big, nice, deep breath. Of course, nobody does that. What happens is you get to the point where you are so hypoxic that you'll open your mouth and just suck all that coffee down into your lungs. Now, if you did the exact same analogy, but you had that person laying on their side when they open their mouth and attempt to take that big, nice, deep breath, what would happen is they're more likely to have that coffee fall out of their airway and not cause that airway aspiration that's going to cause some complications down the road. So start putting these patients on their side like we do with our seizure patients, because the chance of vomiting in the overdose patient is probably equal, if not greater, to what we encounter when it comes to seizure patients, okay? Don't forget that you always turn your patient towards your partner, right? Again, let's let them be on the receiving end of this wonderful individual that we're encountering. So that's my little take on airway. When it comes to breathing, let's take a look at their rate. If their rate is less than 8, it's probably something to do with their central nervous system. Now, if this individual has a poor tidal volume, right, and again, we're talking about shallow breaths, then that BVM is a really, really great tool for you to be utilizing to help that patient breathe just a little bit better, okay? Now, it's a little bit hard for some people to understand the difference between adequate and inadequate breathing. And I talked about this in a lecture a couple months ago. If the patient is adequately breathing, that means their level of consciousness is normal, their rate is within normal limits, their tidal volume is within normal limits, their SpO2 saturations are above that 94, 95% range. There's no reason for us to use a BVM on those patients. There's a really good reason, maybe if they had a complaint of respiratory problems, to throw them on a non-rebreather or a nasal cannula. But if you were here for that lecture, you heard how much of a fan I'm not of the non-rebreather. But if they're inadequately breathing, their rate is lower than, less than 8 or over 28, their tidal volume is less than 300, or some along the lines of those complications, then your patient's more likely to have an altered level of consciousness. Your patient's more likely to have a low SpO2. Your patient's more likely to have a shallow characteristics of that breathing, or almost like a guppy breathing or gaspy style breathing. Then that individual doesn't need oxygen. That individual, you got to fix their tidal volume, and the best way to fix their tidal volume is that little non-rebreather that's sitting on the corner of your screen. The other big one is if there's COPD or something along those lines, or CHF with some fluid shift, you can talk about CPAP, because CPAP is also a positive pressure ventilation device. So kind of keep those in mind when it comes to airway control and what we're doing in that pre-hospital setting, because it's really important that we're taking a look at our patient's tidal volume and rate. I'll tell you, it's really fun. After we get done tonight, if you want to pick someone that you're not a big fan of in your agency there, if you're the only one in the room, sorry. But what you do is you stand up and put something behind you in case you fall, and breathe at a normal tidal volume and a normal rate, right? Breathe at 12 to 20 times a minute. And then for a minute or so, why don't you breathe quickly? Normal tidal volume, but just breathe at a faster rate. And how I usually do it is I put a student in front of the room and I just say, listen, you have to listen to me. When I say breathe in, take a big, nice deep breath. When I say breathe out, exhale. And I time them at a rate of a breath about every 3 seconds. So you inhale and exhale, and then inhale and then exhale. And you speed them up to a rate of about 20 to 22 breaths per minute. And what's interesting is they'll breathe like that for a fairly long period of time, because I'm sure most of you, like me, have been short of breath before, whether you're running or exercising, or like buffet's got free food or whatever, you take a run for the buffet to beat everyone else there. Either way, I'm sure we've all been out of breath at some point in our lives. That's just a rate of 22, 24, or whatever. Now, the second time, what you have them do is you have them take a few normal deep breaths and then mess with their tidal volume. So what you tell them is, when I say breathe in, I want you to breathe in as hard as you can. And when I say breathe out, I want you to exhale as hard as you can. And what you do is you say breathe in, breathe out, and wait 3 seconds. Breathe in, breathe out. And now what you're doing is you're messing with their tidal volume. And you'll notice in about 15 or 20 seconds, that individual will start to get weak at the knees and start to get wobbly. Hopefully they don't pass out and fall down. If they do, someone's got to catch them. It's kind of like a trust fall. But you can really see that the biggest component to this is their tidal volume, not their rate. So start looking at our patient's tidal volume. If the tidal volume is crap, then fix it with the BVM. If their rate is crap on the slow side, fix it with the BVM. If their rate is fast, but their level of consciousness is okay, don't stick the BVM in their face. There's no reason to slow them down if they're compensating really well for the current rate that they're breathing at, okay? I can't stress this enough. Your number one and number two priority in the overdose victim needs to be the airway and the breathing, okay? It's not grab the Narcan, okay? And I'm going to probably share a story with you at some point during this presentation that I've encountered this. But let's look at something else here. This was an interesting title of an article I read when I was doing this research. I was trying to figure this out, is, are we abusing Narcan? Now everyone's like, you can't abuse Narcan. It's benign. It doesn't hurt people. Be careful, because you can abuse it, because you can give it to the wrong people and you can give it for the wrong reasons. Now, I truly don't think that we ever have set out on any of the calls we've gone on, and I don't know all of you personally. I know some of you from each one of these agencies or some of these agencies, but I don't think anybody intentionally sets out and is like, you know what, I'm going to Narcan 5 people tonight. Well, of course we don't set out like that, but I think that we were taught it was used for the wrong things, and that's what we're going to talk about. So first off, here's the problem. Narcan initially is a noun, right? And we've kind of widely turned it into a verb, like I Narcaned that patient. Or you get these dumb bumper stickers or these t-shirts that I feel like make EMS look like just kind of heartless people of, I Narcaned your honor student. I don't know if you've ever seen that sticker before. I maybe wanted to buy one once, but that's not the point. The point is, we've kind of done this where we've created this mentality of, I'm going to Narcan this person, or I'm going to Narcan that druggie, or I'm going to Narcan this person. Here's the deal. The drug itself, the word itself is a noun. It's not you did this, right? We're talking about a thing being Narcan. So kind of keep that in mind. Like I said, it's kind of a mentality, and I'm sure I keep picking on Colfax. You're the only person I can physically see on my screen right now. And I feel like there's a lot of people being like, I think I have that bumper sticker. So put it on your water bottle. Don't put it on your car, because then you get your, people see your car sitting outside the fire station. I don't think that's the time to pass a levy. So Narcan is effective. Narcan is so effective that we have dreamed up imaginary clinical situations to administer it. For example, number 3 in Spokane County, which happens to be coma of an unknown origin. Well, if they're unconscious and we don't know why, let's just give them Narcan just to make sure. Well, maybe we should check a couple of things before we just start Narcanning everybody and using it as a ruling out device. And we're going to talk about the most common time I feel like it's just given as a precautionary measure. And I will tell you, and I'm going to give you a couple examples here in a second, EMS has mistaken common medical conditions we used to treat for overdoses. We now go on the diabetic who we automatically just assume they're overdosed, and we give them Narcan and nothing happens. And you scratch your head and go, that's weird. And then someone checks their pupils and says, well, their pupils are equal, round, and reactive to light. And then you're going, okay, well, maybe we should check their glucose. And you check their glucose and it's 10. Well, guess what? Duh. Maybe you should use your differential diagnosis before you just start hammering people with Narcan. Okay, I'm going to give you a couple examples of when this is actually happened. So, looking here at the next slide. What we're going to look at is a couple of times that we may or may not we personally, but EMS in general. This one was really interesting. A woman in Pierce County Township, Ohio, sustained an anoxic brain injury when police officers thought her asthma attack was an overdose and administered Narcan. Okay, so time out for a second. How many of you have seen asthma attack patients that are unconscious, that are breathing at a rate of less than 8 at a tidal volume that's similar to an overdose patient? Any hands? Most asthma attack patients present with fast respiratory rates, low tidal volumes due to that, but most asthma attack patients are usually conscious and fairly concerned. So why was Narcan given to this patient? I don't know the exact circumstances. I do know that because she was hypoxic for such a long period of time, she ended up with an anoxic brain injury, and that's a pretty critical injury, okay? Now, good news, we can blame it on the police officers, and I mean that totally kidding, right? This wasn't EMS providers, but I'll bet you they've had some training when it came to Narcan that they probably just weren't explaining this drug properly. Here's number 2. Still paramedics would administer 4 doses of Narcan, an opioid antidote, into her arm As it turned out, this was a different case. The 55-year-old artist and holistic medicine believer had suffered a stroke. This individual had suffered a stroke in her home. And when EMS showed up, they administered a dose of Narcan. And guess what? It didn't work. So what'd they do? They gave her another dose of Narcan. And guess what? It didn't work. So they gave her another dose of Narcan. And you get the point? 4 doses of Narcan to an individual who was suffering from a stroke. I don't know about you, but I haven't encountered a lot of stroke patients, unconscious, barely breathing, that are similar or appear like an overdose, right? I just think like we have gone too far when it comes to walking in someone's home and going, this is an overdose, let's give Narcan. Why don't we go back on your differential diagnosis way of assessing people? You can walk in the door of that house that's got the needles in the ground and the constricting bands all over the place, and there's cooked spoons and there's, you know, little baggies of white powder and whatever scenario you can think up that you're like, well, I go to this house all the time and it's obvious they're overdosed. Well, okay, fine. Walk into the door and think on your differential diagnosis list, okay, it's likely they're overdosed. But what are 4 other things that patient could be suffering from that maybe isn't an overdose? 4 other things that in all, you're going to look at and assess for and rule out 5 possibilities that this individual could be suffering from. And then aim your questioning and your assessment and your vitals in those things at marking some of those off and getting it narrowed down to 1 or 2 of those possibilities. Now, I've talked about differential diagnosis before, and the real big recap of that is I truly believe EMS providers at every level should have 5 diagnoses in their mind that you're thinking about in every call, every chief complaint, 5 possibilities that you're going to rule out based on questioning and assessment to work your way through good questioning. If you rely your assessment on sample and OPQRST, that's a really silly crutch that's going to fail you one of these days. Differential diagnosis, in my opinion, is just a much better way of assessing people. So with that in mind, let's say we take a 19-year-old male at a college dorm and they're unconscious and the roommate says, I saw him shoot something up in the bathroom and now he's unconscious, okay? Type in the chat window, what are some possibilities? This is my excuse to actually drink water. I just realized I'm yelling at my computer. I must be getting really worked up. So if it sounds like I'm yelling, I'm really sorry. 5 possibilities. Noni, I love that. Diabetes. Stacy, you put insulin, question mark. Well, duh. Maybe you look at this guy and say, okay, well, does he have any track marks in his arms? If the answer is no, maybe the dumb roommate who said he's quote unquote shooting something up in the bathroom actually doesn't know what the hell he's talking about. And he was taking a needle and injecting something in his abdomen. You might ask some clarifying questions like, where was he shooting up? Well, he stuck a needle in his abdomen. Well, I don't know very many heroin users that shoot up in the abdomen, okay? So in this case, you could throw diabetes up there. Is probably the more likely alternative to the he's shooting something up college student. What about just the generic patient who's unconscious? And maybe it's in an area that, you know, is pretty known for drug activity. What are some other possibilities? What other conditions present similar to overdose patients that you may want to think about on your differential diagnosis list? Come on, there's 24 sites on it. We only got like 2 people participating. So I'm going to make you participate tonight. Stacy, CO poisoning. That's a really good one. What else? Not necessarily you, Stacy. You're killing it tonight. But somebody else. Come on. Colfax, you guys you can't even go to the TV screen and type, so I'll forgive you guys for that one. But ambulance in Plentywood, drunk, absolutely. Alcohol is obviously a possibility as well. What else? Come on, keep going. We've already talked about hypoglycemia. What else? Come on, give me, I got 3 more I can think of. And we kind of already talked about them. A heart attack, maybe, right? I haven't been on a lot of unconscious heart attack victims, but it's definitely a possibility. Plentywood, hypothermia was one of the ones I was thinking of. Nice job. And really, on the heat stroke side, on the hyperthermia side, you could definitely have an issue. Spokane District 5, allergy shock. I don't know what you're talking about. I don't know who that is saying seizure, but you're absolutely right. Who was that?
Great Falls.
Great Falls. And way out in Montana. Nice work, guys. seizure or post-seizure, right? How's the weather in Great Falls, Montana? Is it gorgeous? They already muted their mic.
It's warm.
It's warm. All right, awesome. Colfax could just be a fall, right? A head injury, traumatic brain injury, okay? But those are all definite possibilities of your differential diagnosis, okay? ETOH is alcohol, right? So alcohol, strokes, TIAs, hypoglycemia, hypothermia, falls, assaults, absolutely, head injuries, traumatic brain injuries, seizures. There's 100, I wouldn't say 100, that's an exaggeration. There's 5 or 10 additional things besides overdose that you can throw into that differential diagnosis and that assessment to make sure you're not missing something. And truly, it should take you just a few seconds to ask some questions, do a good assessment, rule some of these out, and move towards the fact of, listen, we got our airway controlled, we got our breathing controlled, we got our oxygenation now up to adequate levels. Okay, now we got some vitals, we got our questions, now we can give our interventions. What are our interventions options? Okay, well, they're not diabetic, so we can't give them oral glucose. We're already giving them oxygen. You know what? Let's go ahead and give them Narcan. Their rate is less than normal. Their tidal volume is impaired. Their level of consciousness is drastically impaired. Let's go ahead and give them whatever dose. If you're an advanced EMT or paramedic, or you're an EMT that's allowed to give this IV, then you give that 0.4 milligrams. Or you give them that 2 milligram dose. In Spokane County, the EMTs can give it 1 milligram in one nostril, 1 milligram in the other nostril, and give it intranasally, and then stand back and get ready for this person to levitate, right? And that's most common, the reaction is we get that nausea, vomiting, violent, agitated response. Not always, but that seems to be like the typical, okay? So let's look at something else here, right? This I truly believe was one of the initial reasons why law enforcement jumped on this Narcan boat really, really early. Who, either raise your hand in Colfax, or I can see Curlew, which it looks like there's just 1 or 2 of you there in Curlew. I see a couple of you people sitting around Lincoln County. Looks like you guys got a good group. But what I want you to do is raise your hand or type into the box if just, yes or whatever, if you've heard about accidental exposures for law enforcement, right? They rubbed against an unknown powder and they all of a sudden got exposed to fentanyl, whatever. Spokane County District 5, you guys said yes. Lori said yes. In Colfax, raise your hand. Anybody heard about the law enforcement? Yeah, of course, right? It created this like pandemonium reaction of, oh my God, even police department canines, absolutely. We had all these issues that we heard about these police officers getting exposed. Curlew piped in with yes as well. Inadvertent exposures to these fentanyls, these carfentanyls, these whatever. So here's what's interesting. I wanted to do a little research and find out how many of these. So here's what's funny. I Googled law enforcement and fentanyl exposure. 337,000 results came up for law enforcement and fentanyl exposure, okay? If you love Google, it tells you how long it took to get that response. Now, let me ask you, someone can type it in, or somebody can raise it up with their fingers. How many of those overdose or those accidental exposures have found to actually been an opioid that affected the police officer, not the dogs, so we're going to go there here in a second, the police officer, in an overdose style reaction? What's the number? 337,000 results. How many of those? Stacy, you're spot on. 0. There has never been a documented adverse reaction to fentanyl from skin contact in law enforcement. It hasn't happened, right? It's a really, really crazy rumor that exploded. Now, canines is a little bit different. I feel like, I don't know this for a fact, but I feel like because they're sniffing around and things along those lines, most police officers I know don't run around crime scenes and sniff things. Unless it's Dunkin' Donuts. Don't tell anybody I said that. But the dogs are getting inadvertent exposures because of how much contact they have on their noses and things along those lines. Law enforcement is vastly different. And all of the times that they actually had a exposure, look at that word, adverse. They might have been exposed to it, but it wasn't enough of the drug to actually cause them to be overdosed. And yet, There's multiple occasions where these individuals are being given Narcan because, oh my God, they came in contact with this crazy white powder, and what if they overdose and die? It hasn't happened yet. I'm not saying it can't, and I'm sure there's an article I might have missed, and if you got that resource, please email it to me and let me know. But all across the country, there are EMS educators trying to make people understand, stop making people terrified of these inadvertent exposures, right? From personal experience here in Spokane, one of the police departments here in our local area came to us and wanted us to educate them on how to treat for inadvertent exposures to fentanyl. And I did a little research and went, well, if you wear gloves and you wear safety glasses like we do, and you don't just snort random white powders off of countertops, then you should be safe, right? I think it's all summed up in BSI Scene Safe. I don't know, and the individual that contacted me was like, can you give a 4-hour class on that? I was like, I can, but I don't know what we're gonna do with the other 3 hours and 57 minutes because we can just cover this right now. Wear gloves. Stacy, no licking patients. Oh my God, you were on a roll tonight. I absolutely, I think next year, raise your hand if Stacy should host a topic in the 2019-2020 season of EMS Live at Night. All in favor? Perfect. Perfect. Colfax, you guys voted. Sorry, Stacy, I'll reach out to you. We'll figure something out. But I really, Plentywood said hand raised. That's awesome. But that's definitely the biggest thing is stop making people terrified of fentanyl, right? Of opioids. BSI Scene Safe, do our job, take care of our patients, problem solved. I think we unintentionally or almost intentionally put ourselves in unsafe circumstances by giving them Narcan. I don't think that being in their home is actually part of that unsafe environment. And like I said, we're going to kind of go through that. So here's where I feel like this truly went wrong is some EMS personnel think that all overdose patients should receive Narcan. Now, the word overdose just means you've taken a dangerous level of a drug, right? Now, this says all overdose patients should get Narcan. Time out. What if it's a beta blocker, right? What if it's a blood pressure medication? What if it's Benadryl? What if it's a sleeping aid? What if it's, right? Unless you know it's an opioid, why are we giving Narcan, right? And believe it or not, this came out of an article. This is not my opinion here. This article even said, and this article was written by Dr. Bledsoe, who authored a textbook, who said others seem to relish in the punishment that Narcan provides to those with this condition. Time out. I don't know about you, but I'm pretty sure I got into EMS and I've heard this idea of first do no harm. If you're giving the drug to punish somebody, you're giving the drug for absolutely the wrong reasons. Now, the story I was going to share with you is I was on a call with one of the agencies that I've worked with in the past. In this agency, we are first on scene, right? We're not a fire department. We're not an ambulance. I won't go into where because it'll give out some information, but we're first on scene. And this individual, initially, the response was for a patient not breathing. And as we walked up to this individual, it was very clear that he was blue in the face, his head was pitched back, and he didn't look like he was breathing. So we grabbed him by the arms, laid him on the ground, got him out of the chair he was in. We grabbed the BVM, and as I went to start to bag him for the very, very first time, he took a big, nice, deep breath and started breathing on his own. And about 2.5 seconds later, he became conscious. Now, he came out of that altered. He came out of that not knowing where he was. He had an interesting backstory. He had just been released from jail about 20 hours or 24 hours prior. And so we got this information from the person that was alongside of us about, he just got out of jail. We're out, we're having a good time. We're celebrating the fact he's not in jail anymore. And the individual I was working with said, I heard him say something about drawing it up. And I looked and he was drawing up Narcan. And I went, time out. What are you doing? I said, if you're drawing it up just to be safe, I'm on board. But what are you going to do with that Narcan? And he's like, well, I'm going to give him the Narcan. I said, no, you're not. The patient's conscious. And he said, yeah, but he's not breathing real good. And what if he's overdosed? He just got out of jail. So nothing with this patient is telling us he's overdosed. But the person I was working with wanted to give it just as a precautionary measure. Well, fine. But the precautionary measure for someone who's not breathing real good, and guess what? This guy's breathing just fine. And the person I was working with said, well, he wasn't breathing a second ago. Yeah, well, he's breathing now. And I don't really feel like giving him Narcan because if he's currently breathing he's currently altered, so he's easier to control, and you give him the Narcan and he happens to have something on board that we take away from him, ooh, we're not going to like what happens when this guy comes up swinging, right? Stop giving it just to give it. And I sure hope that nobody tuning in is giving it to punish patients for this condition of overdose. I feel like that's some extremes. So we've literally talked smack about Narcan for, I don't even know what time it is. Holy cow, it's almost 8:30. I didn't think I was going to get to this presentation, and I thought it was going to take me a half hour to get through it. Man, I talk a lot. What are the dangers of this drug? Does anybody know? You can type it in or you can unmute your mic. What are the dangers of Narcan? Because I don't know about you, but I've been hearing like, well, there's no dangers. There's no side effects. It's a great drug. It's benign, da-da-da-da. What are the dangers of this drug? Anybody know? Seizures, nice guess. Or not, you're the right answer. Acute withdrawal syndrome. Stacy, you're a rock star. What else? Anything else? 5 seconds. 4, 3, 2, 1. DTs, delirium tremens, right? Usually more DTs is more on the alcohol side, but definitely withdrawal-like symptoms. Agitation, you're spot on, right? I don't know about you, but I don't really want to, I don't want to intentionally agitate my patient, right? That's my partner's job, not my job. I'll leave that up to them, okay? So look at this one. This is this progression. This is kind of interesting. First of many of the opioid overdose patients are inpatients who are opiate dependent. Giving Narcan will block numerous opioid receptors, causing the patient to go into full-blown withdrawals. And it's an unpleasant experiment, or an experience involves them being irritable. I love this, sneezing and yawning. Then comes a runny nose that resembles a waterfall. Then comes vomiting. Then is soon followed by copious weapons-grade diarrhea. Right? That's Dr. Bledsoe's words. I wish I would have came up with something as great as weapons-grade diarrhea. Okay? But think about that. And we obviously know that the vomiting comes not very far after that. Okay? Nani said patient refusal because they feel better if they become conscious. You're right. It's just like, you know, and again, it's going to wear off in 20 to 90 minutes. And what's going to happen? You're going to be right back there and they're going to want you to take care of them. And that's the problem, was reading these repeated calls to go back and give more Narcan and give more Narcan and give more Narcan and so on, right? If you want to read a really interesting article, if you just Google 3 strikes you're out overdose rule, there is a county in the Midwest that initiated a 3 strikes you're out rule, which meant if EMS resuscitated an overdose victim more than twice, on the 3rd time, they were instructed to withhold Narcan and let the individual die, right? You want to talk about branching out into an area that EMS probably doesn't want to be involved in. It's using the term 3 strikes you're out, followed by the term let the patient die, right? I feel like this has just got way, way, way out of hand. So that copious diarrhea, then obviously we start talking about nausea and vomiting and airway issues and so on. So those are definitely some of some of those complications of what we're dealing with, right? Acute and abrupt withdrawal increases the likelihood of pulmonary edema, ventricular arrhythmias, and severe agitation, right? And I read that because these slides somehow got mixed around. This one talking about moms and babies, I wanted to talk about in its own thing. But here's the warning when it comes to giving Narcan to anybody. Naloxone should be administered cautiously to patients who are known or suspected to be physically dependent on narcotics, right? If this person takes a drug every single day, be really, really careful when you give it. Now, I'm not telling you not to give it. I'm just telling you make sure you give it for the right reasons, right? When it comes to newborn infants of mothers who are known or suspected narcotic overdoses, Narcan does cross the placental barrier, which could cause the fetus to withdraw inside of mom as well as mom. And you have just created yourself a mass casualty of withdrawal-like victims of 2 patients, 1 victim you can't even do anything about because you gave Narcan to that mom. Now, if mom is overdosed and mom has respiratory depression, then the only best way to treat baby is treat mom. But don't just be giving it because the mom is on board with an opioid or something along those lines. They got to have those indications of why we give this drug in the first place. Because, and we just said this one, acute and abrupt withdrawal increases the likelihood of pulmonary edema, ventricular arrhythmias, and severe agitation. Now, this next analogy, I can't wait for the laughter in Colfax. I can't even hear you guys. I know this is coming. You give the patient Narcan, and what do they turn into? Boom, right? This is the individual they turn into. Nausea, vomiting, agitation, spinning head around in circles, and whatever the case might be. These are the patients that you want to be really, really careful of. A couple months ago, Spokane City Fire had a very close call when they resuscitated an overdose victim with Narcan, and that individual sat up and reached for a gun, and they managed to get the gun away from the individual before he could use it. And if you research, there are plenty of stories and resources and links and examples of that exact thing, okay? So keep those things in mind. I'm not telling you to avoid it. I'm just telling you to use it for the right reasons, okay? The idea of, is it really worth the just in case kind of thing? There is no reason for introducing withdrawals, okay? Especially many patients are on long-acting opioids that last much, much longer than your Narcan, okay? And if you resuscitate them, like Nani was saying, if you resuscitate them, what happens then is they want to sign that refusal, and then they end up in that overdose state just a few minutes after that, and then you're going to be right back there taking care of them. So kind of keep that in mind, okay? Again, your priorities should lie in the BVM and airway control of these patients, okay? The primary issue with opioid overdoses is their impaired respirations, which means your primary treatment should be the primary issue, which is the fact that they're not breathing like they're supposed to, okay? So if you're going to give this, okay, if you're going to give this drug, there's a couple of dosing options for this. Number one, if you're going to give a IV dose, I really don't like this, but the IV dose is a range from 0.4 milligrams to 2 milligrams. If you're giving 2 milligrams of Narcan via IV, you must not like yourself, and you sure in the heck don't like the team that's in the room with you. Because if you slam 2 milligrams of Narcan into an individual via IV, you're really, really not gonna like the response you're gonna get. I'm a big fan, like Stacy said, titrate to nice. I give 0.4 milligrams and I wait a few minutes to see what happens. If their breathing doesn't get better, and I know for a fact this is an opioid, then fine, I can give them 0.4 more. And I love giving this in 0.4 increments, 0.4, 0.4, 0.4, 0.4, with a max dose of 2 milligrams total, okay? That way, we never unintentionally get a severe withdrawal patient, okay? In children, the dose is 0.01 milligrams per kilogram when given IV, okay? If that doesn't work, we give a subsequent dose of 0.1 milligram per kilogram body weight can be administered. Please make sure you check with your local protocols before you start giving drugs based on my advice here, okay? In neonates, the initial dose is 0.01 milligram per kilogram body weight administered via the IV, okay? On the BLS side, if you're giving this, you're gonna open the kit, and most agencies, I don't know about you guys in Colfax, raise your hand because I can see you. Are you guys using pre-filleds, or are you guys drawing up out of the bottle? Raise your hand if it's pre-filled. I saw one hand. Raise your hand if you have to draw it up. Are any of you on the same page? Perfect. I feel like you guys take a lot of drugs in Colfax. Anyways, open the kit. Oh, he's going to the microphone. Or is he going to type? He must be typing. Pre-filled. Perfect. Thank God you guys can follow instructions. I love it. So you're going to open kit or load 2 milligrams into that syringe of that Narcan, which 2 milligrams is 2 mLs. You're going to attach that atomizer nasal cone onto that syringe. You're going to place the atomizer into the nostril, and you're going to briskly compress the syringe to administer 1 ml of atomized spray into one nostril, and then you're going to give it the other milligram in the other nostril. Now, if you dropped an NPA in place, you can't give the nasal Narcan in the nostril with the NPA. Okay, so either A, give the full 2 milligrams in one nostril, pull out the spaghetti noodle, and give the other milligram of Narcan, and then stick the spaghetti noodle back inside their nostril, okay? but don't just squirt the nasal Narcan into the nostril that's got that NPA in place, okay? That's easy. That is our dose for Narcan. That covers BLS, covers ALS, covers advanced EMTs, covers neonates, covers pediatric, covers adults. Really straightforward. Law enforcement, they're most, unless they've got some sort of advanced level provider, they're giving the BLS form of Narcan. Lincoln County Fire District 6, you guys chimed in with pre-fills as well. Awesome. That just takes out the whole calculation and problems that could be participated. Good Lord. I don't know about you, but this is probably not water. All right, so what is the game plan when they wake up? Okay, scene safety is your #1 priority. If law enforcement's not involved, they need to get involved, then get them involved. And then the other one is go back to the basics, because it's likely they're going to have airway breathing issues. So be thinking about those things. Maybe you should have your suction unit ready to go before you give the Narcan. Okay, maybe you should have them already turned towards your partner, so when they start to puke, you don't have to turn them towards your partner. They're already aimed in that direction. Okay, and then if they start to get agitated, I'm a big fan of being like, I didn't give you the Narcan, he gave you the Narcan, and then just take a couple steps back and see what happens, because most of them know what Narcan does. Okay, so blame it on your partner. I'm a big fan of that one. B, really at this point, B should be good, right? Breathing, that was the whole idea of giving Narcan in the first place. So airway is probably the thing that you're going to have to helping them out with. So roll them on their side, protect their airway. You might have to manually do some sort of jaw lift maneuver to open up their jaw, allow them to vomit. Be careful sticking your fingers next to those little biting mechanisms known as teeth, because you don't want them to bite you and you end up with something or injured or something along those lines. So let your partner stick their fingers next to the patient's mouth. That's probably the best option there. So, but kind of keep that in mind when it comes to airway control. So speaking of ABCs, this is probably the one I was talking about. This is the one time that I hear the most, and this created some controversy actually here in Spokane County, which was, does anybody know when the most common time that EMS administers Narcan to quote-unquote rule out overdose? When is it? Come on, somebody tell me. In the chat box, what is the most common time that Narcan is given to rule out overdose? See if somebody gets it. Whoever gets it can have a hat. I'll mail it to the department. I'll even autograph it for you if you want to. You just got to tell me if you want an autograph. Come on, somebody say it. Type it in. Oh, Colfax is running. Good, I know where Colfax is. It's close. Did they got the right answer? Middle of the night. No, not in the hospital. No. Come on, Colfax, give me a different answer. Most common time, not a diabetic. You're getting closer. Not early mornings. I'm not moving on until someone gets the right answer. Not lunch. Good Lord, this has gone south. Colfax, come on. I want to send you guys a hat. Give me a break here. ETOH. Nope, you're really close though, Plentywood. Let's broaden it up a little bit. A medical condition, right? A type of call that you go on that this is not a stroke. Good Lord, Colfax. Come on, man.
Seizures.
Not seizures. You're so darn close. More common. Not difficulty breathing. I'm going to even get one of these hats, right? Look at these beautiful hats that I'm going to autograph for you. Altered mental status. You're getting closer. Elderly overdose. No, keep going. This is a really fun game. Come on. Who wants a hat? If I answer it, I'm taking this hat home with my own autograph. Not epilepsy. 3 more chances. Think of the letters A, B, and C. District 5, you're really
COPD.
Nope, not COPD. District 5, you're really close with unconscious. Come on. Let's see here. I'm going to draw. Not sleeping. I love that. Sleeping. Unconscious, unresponsive. You're so freaking close. How about during CPR? Right? By far, the most common time people give Narcan. Guess what? Y'all suck. This is my hat. You guys can't have it. I'm autographing it. Suckers. And when I come teach Colfax in a couple of months, boo. Don't yell at me, District 5. You just got to ask nicely and I'll give you a hat. CPR, by far, is one of the most common times that people are giving Narcan to just rule out overdose. Here's the deal. If they're in cardiac arrest, your priorities lie somewhere totally different than giving a drug. Where in the American Heart Association guidelines does it tell you one of your priorities during cardiac arrest is to give Narcan? And I've had the argument of, well, wait a second, if you take ACLS, then it says toxins. Yeah, but that's low on your priority list. That's after you've done rounds of CPR. You've given lots of different things already, okay? There is no, and I got to erase this because I actually have stuff on this slide. I didn't know I was going to have to just give it to you, for goodness sakes. There is no clear benefit given to patients with in cardiac arrest. If you got proof and you got extra time, then great, give it. But there's no data to even show that giving Narcan to an unresponsive, or I'm sorry, to a overdose victim who's in cardiac arrest, that giving them Narcan even improves the ROSC in the first place. So there's absolutely no reason to even give it, okay? Absolutely no reason to give it. So if you got extra time and you know for a fact this cardiac arrest is overdose, then great, fine, give it. But if not, I wouldn't worry about it, okay? Worry about CPR, worry about AED, worry about the actual priorities of A, B, and C, okay? Now, are there any new advancements in administration of Narcan? The idea here is titrate intranasal Narcan to restore respirations. And everyone's like, well, wait a second, isn't that what we already do? This idea was really, really interesting. Here's what it was. This was Bledsoe's idea. Putting 2 milligrams of Narcan into a nebulizer, turning the nebulizer on to 6 liters per minute, putting the nebulizer mask on that patient's face, and when your patient starts to become more alert, take off the nebulizer mask, right? That way, you're not giving them an excessive dose of Narcan, and it's intranasally just like you gave that intranasal device. Now, the idea is giving them a very slow titrated effect drug until you get the exact response you're looking for. And in Stacy's case, you're looking for Mr. Nice Guy, right? Or Mr. Nice Girl, okay? When they start to become Mr. Nice Guy or Mr. Nice Girl, take off the non-rebreather that has the nebulizer mask, and let's not give them any more drugs. Shut your oxygen off, and guess what? Now you still have that canister, and if your patient goes back to being overdosed, put it back on their face, turn that nebulizer back on to 6 liters per minute, and give them some more of that drug. And you can play that whole seesaw titration effect game until you get that patient to a hospital and we can get them taken care of. The big thing here is this way they don't become combative and they don't go into opioid withdrawal symptoms, and it's just a way to titrate it. Now, before you go do that, I want you to make sure that you clear that with your MPD, okay? Don't just be like Sean Pitts says. If that's the case, my name isn't Sean Pitts. Don't use my name, use somebody else's. But the idea of titrated nebulized Narcan is fairly new, an interesting idea. You can do a little research. You're probably more likely to get the permission as an advanced EMT because we already get nebulizers, but there is a possibility in 2020 in the new NREMT scope of practice that EMTs get nebulized albuterol as a drug coming to their scope of practice. So this might be a little bit more on the horizon than we think it is, okay? Perfect. It's 7:45 and we are at the post-test, okay? So we're gonna go through the post-test and Colfax is running to the screen. These are gonna start typing the answers, you cheaters. What is the IV dose of Narcan? Type it in. Lincoln County District 6, you guys got it. 0.4 milligrams of Narcan. Right? Colfax, you guys even tried to cheat and it didn't even work for you. All unconscious patients should get Narcan, yes or no? False. Perfect. Nice job, Stacy. Nice job, Curlew. Nice job, Colfax. False. You should give multiple doses of Narcan until the patient is wide awake. Colfax. False. Nice job. Last question. The new delivery method for Narcan that should be discussed with your MPD is what? Lori said, oh, hell no. I love that. Colfax, titrate via nebulizer. Nice job, guys. So that's the end of the post-test. Only had 4 questions tonight, mostly because I didn't want to make any more questions. So here's the deal. Before you all start leaving, right, don't start logging off. Our season of EMS Live is over. I really, really hope you guys enjoyed it. If you want, I love the Bledsoe's approach. You're spot on, District 6. If you guys liked EMS Live at night and you got something positive to say, awesome. You can throw it in the chat box if you would like. so I can read it as I log off for the night. If you got something negative to say, don't put it in the chat box because I can't have that kind of stress on the drive home. But you can put that as in the evaluation. I can't wait to read those, and that's truly, honestly, my opinion. Please let me know what you like, what you didn't like. I'm going to try to work on some sort of end of season evaluation. But I want you guys to know that we will be back September 10th, 2019 at 6:30. That will probably, I don't know if I'll pick a topic that night or not, or just kind of give you an overview of what the season looks like. But the next couple of months, you'll probably see in the website, all of the dates start popping up, all of the presentation topics and so on. My goal for next year, as much as I've absolutely loved presenting twice to 2 to 3 times a month for the last 9 months, I really have enjoyed it. Thank you guys for tuning in. But I'm going to try to get some guest speakers to come in and present on different varying topics in the 2019-2020 season. So that's kind of what's on the horizon. If you want to come, or if you want some more information, if you want some better training, I do have a YouTube channel, so you're more than welcome to reach out to me and check that out. I'm also on social media. If you look up Sean Pitts, lead EMT instructor, you can find my Facebook page on the educator side, and you can follow that page. And I got lots of really good links to YouTube videos and trainings I've done and so on. So feel free to check that out. Our conference is in September 28th at Northern Quest Casino. I'm one of the individuals on the group that's putting that conference together. So keep that in mind. It will be a really, really great conference, I promise you. So please come check us out and join us for that conference. Sorry, I got kind of sidetracked there. We do have that discount code of Housefire 2019 to get you that $70 registration. So check that out. We got an EMT refresher coming up the end of December. It's the only one we're going to offer the rest of the year. So if you're recertifying, you want to come see us. This is a hybrid class, so it's got some online information. It's got some live information. Check it out on our website. Please make sure that you email us your rosters and get those taken care of. I will upload I will upload the course completion document probably on Thursday, so keep your eye out for that, as well as a copy of my PowerPoint. If you want to look at the recorded version of this, I'm going to upload it onto my YouTube channel, which you can find through my Facebook page, or if you just YouTube Sean Pitts, lead EMT instructor, it'll be up there. But you can check that out. I truly do thank you very, very much for an awesome, awesome season. Thank you guys for tuning in. Thank you guys for all the feedback. I'm super stoked to see some of you on some live trainings, as well as on EMS Live at Night in September. Have a great night, guys. Be safe, and I will talk to you guys soon.
You are currently the only participant in the conference.
Goodness sakes already. We're logged off awfully fast.
I don't know why it says that, because it's hardly ever true. We're trying to figure out what's triggering that.
I feel like it makes me really uncomfortable. It's like, congratulations, you're the only one caring.
Sir, you have a wonderful summer.
You as well, sir. I really, truly hope you enjoy your vacation. I hope you do something more fun throughout the summer.
Yeah, we will.
Awesome. It was a pleasure working with you this year, sir. I look forward to next year.
Okay, we're always here if you need anything at all. I did zap you an email with the numbers. Looked like 24 or 25 was the high tonight.
Perfect.
And check in with us.